Hello, ma'am. You can
Huh.
you can start, madam.
Okay.
Yes, ma'am. Start, ma'am.
Mm. Dear students, good evening to you all. I'm Dr. Ramani. I'm Professor of Surgery of Andhra Medical College, Vishakhapatnam. I'm very happy to come into interaction with you. I thank Ramya ma'am for giving me this opportunity. I thought senior semester students also will be there. I thought I'll start GIT. But since you're sixth semester students, let us see how much you can follow. Any doubts you can ask, right? See, this is only to stimulate you. You should go home and study. You should always start studying from embryology, surgical anatomy, physiology, then clinical features of the disease, investigations, treatment, complications, various modalities of treatment, and follow up. So whatever you study, you have to start from the scratch. From the base, you have to begin and study. In that way, you will be covering all the aspects. Since you will be having 14 subjects in your MBBS, when you start in detail, you are covering all those. See, even in surgery also, unless medical management is done, we won't opt for surgery for any diseases that need surgical treatment at the end. So if you read in this way, you can nicely summarize and revise all other subjects too. So today I thought I would start with GIT. I will change and teach accordingly what you want. Those topics I will teach you. I I formulated this presentation in such a way that some amount of theory and then some bits. It is not possible to tell you everything, all the bits that they are there. You also go home and do some bits and you come up with some doubts. Next time in the next class we can interact, right? Today I thought of dealing only with benign diseases of esophagus. I will cover till 1 hour, whatever is possible, and little more. And if anything is more left more in the next class, I will finish. Next class, I'm going to talk about carcinoma of the esophagus. So when we announce a class for you, you should read and come, right? In the textbook of Belly and Love, and also some surgical anatomy and medicine textbooks also you should little revise and come, so that it will be easier for you to understand what we are talking. So now, first, I just want to tell a little of surgical anatomy of the esophagus. You know, this is a muscular tube. This is from the pharynx going up to the cardioesophageal junction. So this muscular tube is having striated musculature in the upper and middle part, mix it in the middle part, and then in the lower part it is a smooth muscle type. Then it has two types of epithelium. The upper part is upper aerodigestive tract is completely covered by stratified squamous non-keratinized epithelium, and the lower part, lower one third, is by columnar epithelium. So this lacks serosa. So the rectum and the esophagus, they don't have serosa. And then there are three important points related to the esophagus relation, that is the 15 centimeters, 25 centimeters and 40 centimeters. Though the esophagus as such is 25 centimeters, we consider it from the lengths that are described are measured from the incisor teeth. So from incisor teeth to 15 centimeters is the upper sphincter, the cricoesophageal sphincter, the cricopharyngeus muscle. The 25 centimeters where the arch of aorta and the left main bronchus cause some constrictions on the esophagus. The 40th centimeter is the cardioesophageal junction, where it is crossing the diaphragm and entering the abdomen. So just remember 15, 25 and 40. These are. Then this is richly supplied with lymphatics and veins. These are oriented longitudinally, and then the layers are the mucosa, submucosa, lamina propria. Next we have muscularis propria, and then the serosa. So the 5 layers are there in the esophagus. Accordingly, we do the T staging of the esophagus. It is not based on the size of the tumor. It is based on the depth of invasion. So these layers are very, very important. The submucous layer is full of lymphatics and veins. It also has muscle. So this is the strongest part of the mucosa. And then if the submucosa is not included in stitching, in applying sutures to the esophagus, there is going to be leakage of the anastomosis. Now, it has two sphincters, the upper sphincter and the lower sphincter. Upper sphincter is at the cricopharyngeus muscle, what I call. The pressure approximately 60 millimeters of mercury. If it is more than this, there are going to be lot of problems like propulsion, diverticulums of the esophagus, etc. And then the lower sphincter is about 1 to 2 centimeters long. It is a physiological sphincter. Anatomically, you may not find as such a lower sphincter. Several mechanisms act to behave like a sphincter. We will discuss it when we are talking about the gastroesophageal reflux disease. The pressure at the lower sphincter is 10 to 25 millimeters of mercury. So this is the roughly the anatomy. But when you are going home, you have to read about all the other aspects like the vascular supply, venous drainage, and all, which is not possible to tell completely in 1 hour. So now before going into the bits, there are 3 types of peristaltic waves that are generated in the esophagus. See, swallowing, when we initiate swallowing, the peristaltic wave, it passes, the swallowing wave will continue as a primary peristaltic wave. So this peristaltic wave goes at 2 centimeters per second, and then by 9 seconds it reaches the lower esophageal sphincter, that is 25 centimeters now, the esophagus. So within 9 seconds, the primary peristaltic wave reaches the cardioesophageal junction, and the cardioesophageal junction opens up when this peristaltic wave reaches the lower sphincter. So now the primary peristaltic waves are normal peristaltic waves which are progressive, which carry the food bolus into the lower part of the esophagus. Next, secondary peristaltic waves also occur. These are due to distension of the esophagus with food. So these are also progressive. When this secondary peristaltic waves also, they progress and open up the cardioesophageal junction. They relax the lower esophageal sphincter, and the food is passed. But there are pathological tertiary peristaltic waves which are non-progressive. They do not contribute to propulsion of food. They do not result in the opening up of the lower esophageal sphincter. So remember this, the primary and secondary can propel the food, while tertiary are useless. So basing on this, we have a bit. Non-progressive contraction of esophagus are primary, secondary, tertiary, and quaternary. So we know that 3 types of peristaltic waves are there: primary, secondary, tertiary. Primary and secondary are progressive. Tertiary is non-progressive. There are no quaternary contractions of esophagus. So the answer here is non-progressive contraction is tertiary. C is the answer. Beware, sometimes bits of AIMS, PGI, and some DNB bits, they have multiple answers. So you should keep in mind which entrance exam you are writing, whether you have multiple answer questions, whether there is any negative marking. So now, see, this second question is, which structure crosses the esophagus at 25 centimeters from the incisor teeth? See, we have read that 3 points of constrictions are there on the esophagus. One is 15 centimeters, which is upper esophageal sphincter. 25 centimeters is the passage of the arch of the left main bronchus over the esophagus. So here we can, since this is a PGI bit, you can keep arch of aorta, left main bronchus. These 2 can be kept. So others, bifurcation of trachea is a little higher. Left subclavian artery does not arise at all. It is in the neck. Next is, which figures are very important to the esophagus scopes? Students, can you tell me, Chaitanya? I have already told you. Chaitanya?
Yes, ma'am.
You tell me A, B, C, D. I have told you, no? 3 constrictions. So the esophagus, when endoscopist, the one who is doing endoscopy, have to be very careful when he is going through this constriction. One is at 15 centimeters, that is at the upper esophageal sphincter, cricopharyngeus muscle junction between the pharynx and the esophagus is called the upper esophageal sphincter, the functional. So 15, 25 is the passage of the left main bronchus and the arch of aorta, and 40 is the cardioesophageal junction. So 15, 25, 40 should be the correct answer. The others are irrelevant. Have you understood, students? Students,
Yes, ma'am.
Yes, ma'am.
are you able to hear me continuously? Is the transmission okay?
Yes, ma'am. It is fine, ma'am.
Then when I ask a question, you should answer, don't know, I didn't understand, please tell me something. I need some feedback. Otherwise, I do not know whether to proceed or not. Is it okay, students?
Yes, ma'am.
Hello? Hello, students.
Yes, ma'am.
Yes, ma'am. We can
Okay.
hear.
So feel free, talk to me, have doubt if I stop. Till now, did you understand the surgical anatomy and the physiology of the esophagus? Students?
Yes, ma'am.
Okay. So now the other question, you have already completed your anatomy exam, so you must be able to tell some answers here. See, when you are doing any questions, first you have to eliminate a process of, if you know the answer correctly, you can nicely pick up. If you don't know, you have to eliminate the irrelevant answers. Then you will be left with the two questions, two answers. Then you have to choose basing on your knowledge. So here, structures not passing through the esophageal hiatus. That means in the diaphragm, there is an opening called esophageal hiatus through which the esophagus passes. So we have, just see what is there. You know, esophagus goes, along with it goes the right vagus, the left vagus. The left gastric artery also can go through it because the left gastric artery originates in the celiac plexus, isn't it? The celiac plexus is from the aorta. So from the celiac plexus, the left gastric artery comes down, and through the esophageal hiatus, it goes down onto the lesser curvature of the stomach. So the answer, you know, now you are left with only left phrenic nerve. You know, phrenic nerve arises from C2, 3 to 5 segments, cervical plexus nerves. So it spreads on the central tendon of the diaphragm. So this does not it does not have to pass through the hiatus. So your answer should be A. Have you understood, students?
Yes, ma'am.
Yes, ma'am.
Very good. So now the normal narrowing in the middle of the esophagus is caused by esophagus vein, hemiesophagus vein, right main stem bronchus, left main stem bronchus. Middle means at 25 centimeters. What is the answer?
Left main stem bronchus.
Yes, very
Left.
good. That is the answer. Very good. See, now you can see how this is the incisor teeth. This is 15 centimeters, cricosopharyngeal junction. The junction, there is a constriction. Here, then the 25 centimeters, you have the arch of aorta and the left main stem bronchus. The 40 is the diaphragmatic sphincter. See, here you can see how nicely in this barium swallow, you can see the first constriction, second constriction, and the third constriction is lost in the cardiac shadow. Now you understood where are the points of constriction of the esophagus, students?
Yes, ma'am.
Yes. So now another bit. False statement about esophagus. This is a PGI bit. So beware, there may be multiple answers. You keep on reading and then you eliminate them. See, you just remember, these are anatomy and physiology bits, so you must very well remember your anatomy of your first year. Thoracic esophagus is supplied directly by aorta. Yes or no? Yes. It is supplied directly by aorta. Bleeding from varices occurs from mid-esophagus. See, now there are some varices means there is some porta-systemic anastomosis are there, right? So some porta-systemic anastomosis are present at cardio-esophageal junction. So is middle, so these, when there is portal hypertension, these porta-systemic anastomosis, the portal hypertension is reflected onto this porta-systemic connections, and the veins of the lower esophagus, they become elongated, tortuous, and dilated. Those elongated, dilated veins are called varices. So we know that the lower one-third of esophagus has this porta-systemic. So bleeding varices should be present in the lower esophagus. So this is wrong. Do you agree? Students?
Yes, ma'am.
Yes. Now cervical esophagus drains to deep cervical nodes. Yes, obviously. This esophagus has a cervical part, thoracic part, and 1 to 2 centimeters of the abdominal part. So the esophagus is drained by all the 3 groups of nodes. That is why 3-field lymphadenectomy has to be done when you are treating a cancer case of esophagus. So 3-field means cervical, thoracic, and abdominal. So cervical esophagus drains to deep cervical nodes is very correct. The level 3, level 4 nodes of the nodes in the neck drain into the cervical esophagus. Now it has rich lymphatic network. Yes, we have seen that submucosa has a rich lymphatic network. That is why when you want to clear a carcinoma esophagus, you have to give a margin of 10 centimeters from the tumor border, because of its rich lymphatic network. Now, the abdominal part of esophagus drains to left gastric. Obviously, that is also correct. So, the false statement here is only thoracic esophagus, bleeding from varices occurs from mid-esophagus. Have you convinced, students?
Yes, ma'am.
Right. Now, coming to diaphragmatic hernia. I will cover topics one by one. I will talk little of anatomy and physiology, some clinical features. Then I will go into the questions proper. Right? Now, the first, I'd like to see, are you able to see my presentation, students?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Very good. Now you see. Now first let us see how the diaphragm develops. So the diaphragm develops from 3 sources: the septum transversum, the pleuroperitoneal folds, and the somites. See, this is the septum transversum, this is the pleuroperitoneal fold, and the somites. So the somites start from the neck. See, from the neck, the muscle originates, and this migrates down along with its nerve supply. That is why the phrenic nerve, which is originating in the neck, is supplying the diaphragm. The diaphragm is descending down along with its nerve supply. Right? So the 3 sources are septum transversum, the pleuroperitoneal folds, and the somites. See, all these develop. The septum transversum develops into sternal and the costal part. That is the pleuroperitoneal. Now, then the anterior part, and all these, they converge onto the central tendon. So this is the diaphragm that you see nicely. This is the sternal and costal part. This is the central tendon and the pleuroperitoneal canal. So here in the central tendon, here we have this orifices. This is the esophagus going. This is the aorta and inferior vena cava. So this is the aorta, inferior vena cava, and the esophagus. 3 are going. Along with the esophagus, 3 structures are going: the left gastric artery and the right and left phrenic nerves. So now let us see what happens if there is congenital diaphragmatic hernias. So this congenital diaphragmatic hernia occurs when the diaphragm is failed to form correctly, and incompletely it has formed, resulting in weak areas. So now, when there are weak areas, the contents herniate, the abdominal contents herniate through the diaphragm into thoracic cavity. You know, diaphragm is a skeletal muscle. It separates the thoracic cavity from the abdominal cavity. Abdominal cavity has more pressure because of more structures. So this pressure drives the structures into the thoracic cavity through the weakened part. This is called herniation. You know what is the definition of hernia? Hernia means protrusion of part or whole of a viscous through a normal or an abnormal opening in the wall of the containing cavity. So here the wall is a diaphragm. There is an abnormal opening because of the weakness. Through this abnormal opening, the contents of the abdomen are coming down. Or sometimes a normal opening can be there. Normal opening is the esophageal hiatus. You know, from the esophageal hiatus, if the hiatus is weak, the stomach can herniate. This we call as hiatus hernia. So weak part means it is diaphragmatic hernia. Abnormal opening means diaphragmatic hernia. A normal opening and herniation is a hiatus hernia. So now, when the abdominal contents are going into the thoracic cavity during the antenatal period, during development, they are occupying the place and the lungs are prevented from developing to the fullest extent. So the lungs are hypoplastic, not only because of the structures occupying the pleural cavity, it is also because some genetic abnormalities themselves which prevent the lungs from developing to their fullest extent. Right? So now the congenital hernia, diaphragmatic hernias occur in the sternocostal part. This is the pleuroperitoneal canal. The right posterior is called Bogdalak hernia. Posterolateral. Sorry, it is left side. Left and posterior. So this is the Bogdalak hernia. Anterior is the sternal attachment. Here if it is hernia. So this is called Morgagni's hernia. Central tendon hernia is called central hernia. So 90% are through the posterior pleuroperitoneal canal. These are called Bogdalak hernias. Just remember this. Next, these are congenital hernias. Acquired hernias occur from when there is any trauma, penetrating injury, like somebody with long instruments producing injury, or hiatus hernia itself, iatrogenic. So these are the iatrogenic means some unknown cause that they have occurred. So these are acquired causes. The congenital causes are 90% is a Bogdalak hernia, and then the rest is the Morgagni's or the anterior hernia and central hernia. These are rare hernias. So the 90% is left and posterior and to the left, right? So now, I told you some genetic abnormalities are there associated with diaphragmatic hernia. One is the Ehlers-Danlos syndrome. This is one you just remember. This syndrome is associated with several hernias. They are also associated with inguinal hernias also. So just remember this Ehlers-Danlos syndrome. Next is see here. Now coming to the diagnosis. How do you diagnose this? Is a neonat. See, you have, what are these? These are all bowel loops. Where are they? In the thoracic cavity. Why should the bowel go into the thoracic cavity? Because of herniation. So this shows that gas bubbles or fluid, the intestinal loops, gas fluid level behind the heart. These are all the diagnostic. So barium meal. So in a case of adults or later presentations, a barium meal is the best method of diagnosis. See, this is a plain X-ray which is showing. You can even give a barium swallow to the patient and you can barium meal. But you not be careful. But even as plain X-ray is showing the intestinal loops in the thoracic cavity. So now let us do some bits. Which of the following is the most determinant of prognosis in neonatal congenital diaphragmatic hernia? That means it is telling what will be the outcome of the patient. Neonat means newborn. Is it the pulmonary hypertension that decides the outcome, the delay in surgery, or the size of the defect, or the gestational age? Is it a preterm? Because of the baby's preterm, it will not survive. So here, the pulmonary hypoplasia leading to pulmonary hypertension. This is the single most factor that decides the prognosis. If the lungs are not developed well, even if you do surgery also, the baby is not going to survive. Even preterm children also neonat also can be nicely brought up in an ICU, neonatal ICU. But the lungs are not developed means definitely it's not going to survive. So the pulmonary hypertension due to pulmonary hypoplasia is a factor which determines the outcome of the neonat. Next question is, which of the following is the least important prognostic factor? Again, same four. The least important is the size of the defect. So this is the one which is going to affect. Next, all are true about Bogdalock hernia. Posterolateral, left side, present in second decade, congenital. So posterolateral is true or false, students? It is true. It is to the left and it is posterior. So this is true. Left side true. Present in second decade. Is it true?
No.
No. So it is a congenital problem. Rather than this Bogdalock hernia is a congenital problem. So the present in second decade is wrong. Right? Most common organ that herniates in Morgagni's hernia. Spleen, liver, stomach, transverse colon. Morgagni's anterior hernia. So anteriorly, which structure is present? It is a transverse colon because it has a mesocolon. So it is mobile, isn't it? So transverse colon will migrate into the thoracic cavity most commonly. Are you convinced, students? Students?
Yes, ma'am.
Yes.
ma'am.
So next, the diagnostic feature of congenital diaphragmatic hernia on prenatal ultrasonogram. This is Ames bit. So cyst behind the left atrium, mediastinal shift with normal heart axis, peristalsis in the thoracic cavity, absence of gas bubble under the diaphragm. So which are the questions? So here, a cyst behind the left atrium, we can't say it can be a fluid level, but it cannot be a cyst. So this is not sure. Mediastinal shift with normal heart axis, yes, because in the thoracic cavity, lot of contents have come, the mediastinal can shift. Peristalsis in the thoracic cavity, yes, this can be, we can see if there are a number of bowels, you can nicely see peristalsis. Absence of gas bubble under the diaphragm is a feature of tracheoesophageal. It is esophageal atresia. With esophageal atresia will not have a stomach gas bubble because if the lower esophagus atresia means absence of canalization. So now, if the lower part of the esophagus is not canalized, the gas will not go. So this is a feature of esophageal atresia. So now we are left with B and C. Are you convinced, students?
Yes, ma'am.
Most common site of Morgagni hernia we have already seen, anterior. Left and anterior. Left and anterior is the Morgagni. Left and posterior is the Bogdalock's hernia. In congenital diaphragmatic hernia, all are seen except common on left side. Yes. Abdominal distension. Can there be an abdominal distension when everything has migrated into the chest? Students?
No, ma'am.
Yes.
No.
So no. The abdomen will be empty. The baby will be dyspneic. You can hear peristaltic sounds if you put your step on the chest. So this can be detected antenatally. Yes, the ultrasound scan. Prenatally, you can detect the bowel loops. Heartbeat shifted to right. Yes. So here except means abdominal distension is the answer. Are you convinced, students?
Yes, ma'am.
Yes. So next, again, Morgagnis hernia is between the costal and sternal part. Hernia through the pleuroperitoneal canal. Hernia through the lumbar triangle. Hernia through the inguinal canal. It is not from the inguinal canal, no? Hernia through
Yes,
lumbar
ma'am.
triangle is called Petit's hernia.
No.
Hernia through the pleuroperitoneal canal is called Bogdalar's. So hernia between costal and sternal part is the Morgagnis
More
hernias.
than that.
Understood? So a neonat with a scaphoid abdomen and respiratory distress has a diaphragmatic hernia. Do you agree?
Yes,
Students?
ma'am. Yes.
Huh. So if there is a congenital pyloric stenosis, there will be a palpable the stenotic segment. The patient will have a lump abdomen. In the volvulus of sigmoid or intestine, midgut volvulus, there will be distension because of intestinal obstruction. There will be abdominal distension. In Wilms tumor also, this can it is not a neonatal. This is not a neonatal problem. Wilms tumor will occur within 2 years. It is a nephroblastoma that occurs under 2 years children. So this is not a neonatal problem. So volvulus excluded because there will be lot of abdominal distension. Wilms tumor will not be there in the neonat. And congenital pyloric stenosis will have a small lump that is palpable. And the scaphoid abdomen is not. So diaphragmatic hernia is the answer. So now we have completed the diaphragmatic hernia. Now we have come to the hiatus hernia. Hiatus means, see, till now diaphragmatic hernia means herniation through weak part of hernia, weak part of diaphragm. Now hiatus hernia means herniation through a weak hiatus. Hiatus means opening. So we are dealing with esophagus. So esophageal hiatus. That is what we are dealing. You understood what I am talking? What is a hiatal hernia? Students?
Yes, ma'am.
So here see, this is the diaphragm, this is the esophagus, this is the cardiac junction which is 2 centimeters beneath the diaphragm. This is a normal orientation of the esophagus, cardiac junction and the stomach. But here what happened, the cardiac junction has herniated and gone up into the thoracic cavity. This is called type 1 or sliding. So the cardiac junction and the upper part of the stomach, the fundus, have slided into the thoracic cavity. This is called type 1. Now, type 2 is called the paraesophageal or rolling, where the gastroesophageal junction is preserved under the crura of the diaphragm. It is well in the abdominal cavity, but para means beside the esophagus, since the hiatus is large, big, dilated, the fundus has a place to herniate. So this is called paraesophageal hernia or a hiatal rolling hernia. Now we have type 3 where it's mixed. That means we have a sliding component. We also have a rolling component. So there is a paraesophageal component and the cardiac junction also has rolled into it. So now, out of all, 95% are type 1 or sliding hernias. The hiatal hernias, 95% are type 1. If there is a paraesophageal hernia, it is almost always associated with a sliding component. These are more common in females and it's an autosomal dominant mode of transmission. And the most common structure to herniate is the fundus of the stomach. Sometimes, if the hiatus is big enough, other structures are also pulled up. See, to the fundus is attached the spleen, isn't it? the short gastric vessels will supply the spleen. So when along with the stomach, the spleen also can herniate. And along with the stomach is also attached to the transverse colon by the gastrocolic ligament, which continues as the greater omentum. So when the stomach is pulled, the transverse colon is also pulled and omentum is also pulled. In this way, even small bowel loops also can go through. So this is called type 4 hernia, where there is lot of herniation, lot of other organs. So here you can see large hiatus, so much big hiatus. This is normal. When this is so much big, the stomach has herniated, along with the spleen will go, the transverse mesocolon will go. Then this is called type 4 herniation. This is a life risk sometimes because of those so many structures going on. There can be constriction, ischemia, and gangrene. Okay. So now coming to clinical features. Heartburn, because the lower esophageal sphincter is no more working. The cardioesophageal junction is lax now. So the acid reflux will occur. So patient will present with the acid burn, epigastric pain, retrosternal pain, and dysphagia. And then postprandial fullness and regurgitation because the sphincteric effect is lost. So vomiting, weight loss, anemia, respiratory, sometimes aspiration also can occur. So they also have hematemesis and anemia. I'll show you why. The diagnosis is barium swallow. This is the most important diagnosis. Endoscopy will show only erosion, mucosal erosions. Next, sometime manometry is needed to determine the motor function. So treatment is you have to replace or reposition the structures that have herniated into the thoracic cavity, bring them back, narrow the hiatus, and then you fix the esophagus to the hiatus. So I'll show you what are these. Hiatus. So this transabdominal laparoscopic repair, hiatal repair is the gold standard. So now we have a name here, see, Cameroon ulcer or riding ulcer. What is this ulcer? When the esophagus is rubbing against the diaphragmatic crura, there is erosion and bleeding. So this is called constant abrasive force of diaphragmatic hiatus. Or as the stomach and the esophagus, this causes the ulcers. So this is more on the gastric mucosa because it's pulled up into the thoracic cavity. So this produces bleeding and patient presents with not only heartburn but also anemia. So now let us do some questions on hiatus hernia. The most common complication seen in hiatus hernia is esophagitis, aspiration pneumonitis, volvulus, esophageal stricture. So what is more common, students? Obviously, esophagitis. See, earlier, it starts with esophagitis. Aspiration pneumonitis occurs in late stages. Volvulus in late. Esophageal stricture of the ulcer also is late. So, most common is esophagitis. Now, true about sliding esophageal hernia in all cases. So, this is a PGI bit. Beware, be for ready for multiple answers. Esophagus always short. Cardia goes through hiatus. So this is sliding hiatus. So sliding means the cardia goes through hiatus. Is this correct? Yes or no, students?
I think fundus.
Cardia is going through hiatus is correct, no? For sliding. So cardia and fundus go through hiatus. That means it is a sliding, no, it is a rolling, paraesophageal. So this is not a correct answer. Peritoneal sac goes with paraesophageal hernia. May or may not go. So this D can be correct. And then B can be correct. B and D should be the answers. Do you agree? Students, cardia and fundus going means it is type 3 hernia. Students, do you agree with me? Students? Hello?
Ma'am, cardia and fundus, second or third, ma'am?
Third. The first one is only cardia. The second one is only fundus. The third one is mixed. Cardia going, fundus also going. So sliding and rolling. This is type 3. So here he is asking only about type 1. So this should be cardia goes through hiatus, and peritoneal sac goes with paraesophageal hernia. It may or may not go. So it can also be kept. Do you agree?
Yes, ma'am.
Huh. So next question. 55-year-old male had retrosternal discomfort unrelated to physical exertion. Pain gets worse after lying down. There is partial relief with antacids. So the most likely diagnosis is, see, in ischemic heart disease, the pain, retrosternal pain is related to physical exertion. So this here it is not related to they have given. So ischemic heart disease is ruled out. Carcinoma esophagus. In carcinoma esophagus, if there is ulcerated growth, the pain will never decrease with antacids. So this is ruled out. Next, Achalasia cardia. Achalasia cardia. This and it. Let us see. So we are left with the two things, C and D. So what are the symptoms of hiatus hernia? What are the symptoms of achalasia cardia? So achalasia cardia also can have esophagitis. It can also have retrosternal pain, but it will also have regurgitation, that is foul smelling contents coming out along with this. So it cannot be relieved completely with antacids. So here now, after achalasia cardia ruled out because there is no regurgitation of foul smelling contents, we'll discuss. I think you are aware of achalasia cardia now. 6th semester means ENT going. I think 7th semester you will have achalasia cardia. Right. So hiatus hernia is the most esophagitis because of the sliding component and the lower esophageal sphincter mechanism is lost. He is having reflux of acid from the stomach. So this acid, if antacids are given, it will decrease, nullify. So the D should be the answer. Okay, students, we'll come and see achalasia cardia later. Next, most useful investigation in the sliding hernia in female. So in sliding hernia, what is the most? So you must be able to see the cardioesophageal junction going up. So is it fluoroscopy? Fluoroscopy means a continuous X-ray. X-ray cannot tell us. Barium meal. Barium meal means it's a contrast. The patient is asked to drink barium sulfate solution. So here you can nicely delineate the esophagus, cardioesophageal junction and stomach. So you can see that the cardiovascular junction has migrated into the thorax. So palpation, clinically you cannot palpate the esophagus. Ultrasound is not going to tell us much. So barium meal is the answer for this. Next, for hiatus hernia, investigation of choice is again barium meal, upper GI in Trendelenburg position. In Trendelenburg means head down position. If you keep the patient after a barium meal in head down position, if the sphincter is lax, the barium will come from the stomach into the esophagus. So now you can nicely see the esophagus and the stomach. So the answer is for hiatus hernia, barium meal in upper GI in Trendelenburg position. Next, fundoplication is used in the treatment of. Fundo means fundus. Plication means stitching. So the fundus is stitched around the lower part of the esophagus so that it will not migrate into the thorax. So fundoplication is a feature of hiatus hernia. In achalasia cardia, I will tell you there is absence of neurons, so the lower esophageal sphincter cannot relax. So the treatment is a myotomy. You cut open. So Heller's myotomy is a feature of achalasia cardia. In congenital hypertrophic pyloric stenosis, it is a Ramstead operation where you do pyloromyotomy. In C esophagus, you are going to do an esophagectomy. So your answer is here hiatus hernia. Are you able to understand, students?
Yes, ma'am.
If you're not able to follow anything, please tell me. I'll wait for you. It is very difficult, I know. The theory classes have not, but definitely I'm explaining. Are you able to catch up, students?
Yes, ma'am. Yes, ma'am.
Only one is telling yes, ma'am, out of 12.
Ma'am, can you again explain about Trendelenburg position in barium meal?
Huh. You know, Trendelenburg position is head down. You understood? Patient is kept in such a way that the head is lower than the legs position. They have tilted the bed to head down position. This is called Trendelenburg position. Have you understood the position first, students?
Yes, ma'am.
Now, when there is a sliding of the cardioesophageal junction into the thorax, now the lower esophageal sphincter mechanism is lost. I'll show you all what is that sphincter. So now the barium nicely goes into the, from the stomach into the esophagus. Understood? Barium meal. Barium meal means the barium has gone into the stomach. Barium swallow means it is esophagogram. That means it will tell when the patient is swallowing, they will take a picture. You can see only esophagus. Barium meal means you should not see esophagus. You should see only stomach. Right? But now
Yes,
the,
ma'am.
the barium has gone reverse from stomach into the esophagus because of the Trendelenburg position. Here the patient will have the acid coming when he is bending down to tie the shoes or to pick up something. He can feel the acid coming into the esophagus and he'll have a retrosternal burning pain. Even he can have a bitter fluid into the mouth also. So now you understood how this reverse the Trendelenburg position and barium meal are diagnostic of hiatus hernia?
Yes, ma'am.
Huh? Right. Now see here, I'll show you. This is the stomach. This is the cardiophageal junction. This is the stomach that has migrated into the thorax, right? This is the esophagus. Now patient is kept in Trendelenburg position. So nicely you can see barium in the fundus. Understood, students? Seeing this barium meal? Students?
Yes, ma'am.
Right. Now, retrocardiac lucency with air fluid level is seen in hiatus hernia, distal end esophageal obstruction, eventration of diaphragm, none. See, air fluid level is seen in which one? Hiatus hernia will not have an air fluid level, so it should be distal end esophageal obstruction. This should be a Achalasia cardia. So here, right? Next. So now we have completed the hiatus hernia. Now let us go and see gastroesophageal reflux disease. Have you understood hiatus hernia?
Yes, ma'am.
Yes, ma'am.
Huh? So from we have sliding, we have paraesophageal, we have mixed, and we have type 4 where apart from stomach, other structures are also entered the thoracic cavity, right? So now gastroesophageal reflux disease is where the gastric contents are refluxing into the esophagus. Normally, they should not go into the esophagus. But due to the failure of the lower esophageal sphincter mechanism, the continence of the lower esophageal sphincter is lost. So the stomach contents are going into the esophagus. This is called GERD. So now I told you the lower esophageal sphincter is not a, it is not a, structurally we don't have anything like a sphincter. It's only physiological that is there. So what are those? First is the esophagus entering into stomach at an acute angle. So the contents of stomach cannot go into the esophagus. Next is intra-abdominal section of esophagus is compressed, the walls, because of the positive intra-abdominal pressure. Now, the folds of mucosa at this junction are also closed and they also have some closing effect. Next is the right crust of the diaphragm, the muscle has a pinch cock effect. It will just compress the esophagus from remaining open unless a peristaltic wave comes. Right? So these are some effects. See here you can see this is the external sphincter. This is the diaphragm. This is the diaphragm. These are the muscles, and so and this is the squamocolumnar junction. Right? Now, due to some disease or some drugs, the lower esophageal sphincter pressure is increased or decreased. So just see carefully, some bits may come basing on these. So some drugs like prostaglandins, progesterone, progesterone is always a muscle relaxant throughout. It keeps the uterus relaxed. Along with it, it keeps all the muscles in the body relaxed. So the morphines, meperidine, theophylline, barbiturates, dopamine, atropine, nitrates, chocolate, coffee, alcohol, peppermint, smoking. See, when we ask the patient to modify his lifestyle means stop all these drugs, stop taking chocolate, excess of coffee, alcohol, peppermint, smoking, because all these are going to relax this muscles at the lower end. Now this, suppose the patient is having this problem, you can nicely give him domperidone, metoclopramide, prostaglandin, F2 alpha, antacids, gastrin, motilin. So these are the structures, the chemicals that increase the lower esophageal sphincter mechanism. Next is the classical triad of symptoms are retrosternal burning pain, epigastric pain, and regurgitation. So these are the three symptoms that the patient will have. This is next. Any patient coming to us, obese patient, obese people have lot of fat in the diaphragm, and diaphragm cannot have that pinch cock effect on the lower esophagus, and then hiatus is relaxed. So these more common in obese individuals. And then so if they have this burning pain, epigastrium and retrosternal region, regurgitation is different from vomiting. Regurgitation is the esophageal contents coming out. So now passively. So what happens if you constantly, if there is gastroesophageal reflux disease, constantly acid is coming, so esophagus gets eroded. So the esophagitis occurs. Now this ulcers heal with strictures where we have Satchki's ring, etc. And then can be Barrett's esophagus. I'll tell you what is Barrett's esophagus later. Next is how do you diagnose? First and foremost, for esophagus, first is always endoscopy. You can directly visualize what is there, what is not there. People coming with pain and regurgitation means first you have to go and see what is there. But the gold standard is 24-hour pH monitoring. When the acid is coming into the esophagus, the pH of esophagus increases. So the patient is made to wear some monitor which tests the pH of the esophagus for 24 hours, right? So now, if there are episodes or spells of increase in the acid several times in the day, that is the gold standard and for diagnosing GERD rather than endoscopy. Endoscopy will only tell the effect of this pH acid reflux. Late stages you can see erosions, ulcers, strictures, and you can also exclude a carcinoma. Now we have a scoring, D-master scoring related to GERD, reflux esophagitis, where the patient after made to wear this monitor, that these points are recorded. What is the total time pH is less than 4? What is the percentage of upright time with pH less than 4? Upright means he is not sleeping. Supine means is lying down. What are the number of, there can be recordings of this pH. The reading will be there, electronic readings. So what are the number of refluxes? What are the number of refluxes episodes more than 5 minutes? What are the longest reflux episode? So basing on this, there is a score generated. If the D master score is greater than 14.72, this indicates that the patient is having GERD. But so this is one method. So just remember D master score is associated with gastroesophageal reflux disease, and the reading should be more than 14.72. So next, what is the treatment of the gastroesophageal reflux disease? Lifestyle modification, medical management, you give proton pump inhibitors. If the patient is not responding, you do a surgery. You have to do anti-reflux surgery. That means what are all weak, you repair all those structures, and then all the sphincter mechanism, and then you do fundoplication. I'll tell you where is that fundoplication. What is that also I will show you later. So let us do some bits now. Lower esophageal sphincter pressure is decreased by alcohol, fat, peppermint, protein. Which one? So we have seen all these three come under decreased, but protein does not decrease. Do you agree, students? Students?
Yes, ma'am.
Ma'am.
So now the gold standard for diagnosis of GERD is 24-hour pH monitoring. You understood? Any doubt?
No, ma'am.
Next, see here the symptoms they have given. You have to see in nowadays in NEET exam, there will be given some symptom complexes. Then you have to diagnose clinically. They may also give a picture of an X-ray or a barium meal, then or a specimen. Basing on that, they will ask a question. So everything you should see nicely. Even in your textbooks, also you should see the pictures that are given, not just going light reading. So here, a 35-year-old lady presented with dysphagia, nocturnal asthma, and weight loss for 6 years. The most probable diagnosis is, see, the 6 years, so malignancy can be ruled out. Do you agree? Malignancy will be short duration. Now, dysphagia, there is difficulty in swallowing. So what are, so here whatever they have given all related to esophagus, so dysphagia can be there in all. We cannot. Nocturnal asthma, they have told nocturnal asthma. That means nocturnally the acid is regurgitating into the reflexing into the esophagus, so much so that it is coming up to the middle 1/3 and upper 1/3 of esophagus, where there can be irritation of the larynx and the upper esophagus, where it will produce as asthma. So this nocturnal asthma will just give us hint to gastroesophageal reflux disease, which is not there with Achalasia cardia. Achalasia cardia, the lower esophageal sphincter is very spasmodic. It cannot relax. So by night it will not relax. So Achalasia cardia is excluded. CA esophagus excluded. And then stricture of esophagus also. Stricture means obstruction. So it cannot be on nocturnal asthma. So we are left with gastroesophageal reflux disease. Do you agree, students?
Yes, ma'am.
Are you there with me, or you are just you're seeing your mobiles or something?
Yes,
You're
ma'am.
there
Yes,
now?
ma'am. We are listening.
Very
Yes,
nice.
ma'am.
Because I cannot see any one of you, that is why. Which of the following is the earliest indicator of pathological gastroesophageal reflux in infants? See, infants also can have the GERD. So, respiratory symptoms, postprandial regurgitation, upper GI bleed, stricture esophagus. Earliest indicator, see, earliest indicator
Postprandial regurgitation.
is, see, which of the following is the, so these can be multiple questions, but see, read the question correctly. Is means single. They're expecting single answers, and this is the earliest indicator of pathological gastroesophageal reflux. So patients, students are, sorry, the neonates always vomit. So we cannot, for anything and everything they vomit. If you don't burp them properly, they may vomit. So this cannot be a indicator of GERD. So respiratory symptoms are the earliest indicators, because I told you they may aspirate some small amounts of the feed, and produce infection, lung infection. So you should be aware if the patient, if the neonat is getting repeated attempts of respiratory complaints, you have to be aware that there may be a GERD, and you have to give them some prokinetic drugs to increase the spasticity of the lower esophageal sphincter. Next, the most important pathophysiological cause of GERD. 1. Hiatus hernia. 2. Transient lower esophageal sphincter relaxation. 3. Lower esophageal sphincter hypotension. Inadequate esophageal clearance. So here, the most common cause of gastroesophageal reflux disease is transient lower esophageal relaxation. So normally, the lower esophageal sphincter should be contracted. It relaxes only with the onset of peristalsis of the esophagus. So until then, it should be tight. But sometimes, due to various reasons, it transiently relaxes, allowing the positive pressure in the abdomen to push stomach contents into the esophagus. So the answer is transient LES, while the rest may or may not be there. In GERD, what demonstrated the best anatomical picture? GERD, best anatomical picture. See, he is not asking any physiological or gold standard. So anatomically, what you should see again, barium swallow. So barium swallow will tell us that you can nicely delineate. See, you have taken a contrast and you take an X-ray, it will show the esophagus and gastroesophageal junction, that the gastroesophageal junction is open. And right, so this should be the answer. Next, most common complication after nascent fundoplication. This is difficult for you. Now, reflux esophagitis is prevented by. So how can you prevent? The thing is long intra-abdominal esophagus. This is the answer. So when you pull it down and keep it in the abdomen, the lower esophagus, then because of positive intra-abdominal pressure, it will keep close, right? So long intra-abdominal esophagus, then increase intra-abdominal pressure, yes. Right crust of diaphragm also has a role. Increase intrathoracic pressure, no, right? So we can see ABC in this question, right? Next is most common cause of esophagitis is esophageal reflux. Complications of reflux esophagitis. So once there is reflux of acid, some structural changes occur in the esophagus. One thing is, once the constantly acid is there in the stomach, in the esophagus, the lining of the esophagus changes. Normally the lining is stratified squamous, non-keratinized epithelium. The lower part can have columnar epithelium. Now it becomes intestinal epithelium. It changes into metaplasia into intestinal epithelium. This is called Barrett's esophagus. Now we have seen that peptic ulcers can occur, esophageal ulcers can occur, which heal with a stricture. This stricture has a name called Sachs-Key's ring. So all of the above is the answer. Next. Which one of the following drugs exacerbate refluxes? So here chlorpropamide, metoclopramide, cisaprediol, prokinetic drugs which increase the sphincter spasm. Well, theophylline, we have seen that it decreases the sphincter spasm. So now the aim of preventing reflux esophagitis is, I told you, bringing the stomach inferior to diaphragm, because the GERD is associated with hiatus hernia. So when you are repairing the hiatus hernia, you should see that the esophagus is brought down. Esophagus will migrate into thoracic cavity. I told you, in hiatus hernia. So you have to pull it down, then reconstitute the angle of Hill, that is the acute angle between the esophagus and the fundus. Repair of defect in the diaphragm. D, all of the above is the answer. Next, coming to fundoplication. Let's see what is this fundoplication. I told you the fundus of the esophagus is rotated round, sorry, the fundus of the stomach is rotated round the esophagus, either anteriorly or posteriorly, and it is sutured onto the esophagus to keep the continence. This is called fundoplication. Plication means stitching. So if it is rotated 360 degrees, it is called Nissen's fundoplication. Right? Next, Rossetti Hill modification of Nissen's fundoplication is only anteriorly the rotation is occurred. I will show you the pictures of fundoplication. Basing on the degree of rotation of fundus anteriorly or posterior to the esophagus, these are various names. Nissen's, I told you, 360 degrees. Then Tope is 270 degrees posterior. Then you have a door, 180 degree anterior. Watson is 90 degree anterior. So just you have to keep reading several times, then you will understand. We cannot tell in one class. Since now you are only in 6th semester, when you really come to your 9th semester, this is going to be a second reading for you, and you will definitely remember. So Belsey mark 4 is 270 degree anterior fundoplication. See here, you can see various procedures. This is the hiatus, esophageal hiatus. Here you can see the stomach has entered into the thoracic cavity. So what they did, they pulled the stomach down into the abdomen and they have closed the esophageal hiatus. They fixed the cardioesophageal junction to the hiatus, and they also have, so this is called Belsey mark 4 operation. So Nissen's fundoplication, I'll show you. This is the fundoplication. You stitch the fundus on either side, see nicely. So now that the esophagus cannot migrate into the thorax, and then this also keeps the lower esophagus compressed. So this is called fundoplication. So now we'll go to the next topic of Achalasia cardia. Students, have you understood what I am talking? Till now, we have
Yes, ma'am.
diaphragmatic hernia, hiatus hernia, gastroesophageal reflux disease. I have covered. I will also cover Achalasia cardia, and we'll stop with this. Is it okay for you? Because it's already 8:10. Students?
Yes, ma'am.
So, Achalasia cardia. See, achalasia means failure to relax. So this sphincter is constantly hypertonic with the periods of relaxation. So here, the muscle of the esophagus, that is the body, and the lower esophageal sphincter, both are affected because of destruction of nerves to the lower esophageal sphincter. There is a degeneration of neuromuscular function of the body. Esophagus is secondary. So both are there. The body is affected, the nerve supply to body, nerve supply to the lower esophageal sphincter. Both are affected. So there is no relaxation. So the esophagus dilates. There is a lot of stasis of food in the esophagus. This produces esophagitis. In long-standing condition, these long chronic irritation can produce metaplasia of the lining epithelium and a squamous cell carcinoma. So Achalasia cardia is pre-malignant. You should be careful. Achalasia cardia is to destruction of nerves. Achalasia cardia is failure of the lower sphincter to relax. Now, there are some fancy questions. AAA syndrome or Algrove's disease, where there is achalasia, alacrimia, and ACTH resistant adrenal insufficiency. So remember, this AAA is Algrove's disease, just for the sake of completion. So what is happening? Why the nerves are lost? Because of selective loss of inhibitory myenteric neurons in the Auerbach's plexus of the esophagus that normally secrete the VIP and nitric oxide. Nitric oxide is for relaxation of the smooth muscle. So when this is not secreted because of the absence of inhibitory myenteric neurons, failure of the lower esophageal sphincter to relax, and the esophageal body also, there is no peristaltic wave that is generated. We have seen that there are primary and secondary peristaltic waves. that start in the esophageal body. So now these are not generated. So there is a functional obstruction at the level of GE junction, and this leads to gradual dilatation of the esophagus. The triad of symptoms are dysphagia, regurgitation, and weight loss. The regurgitation of food is undigested food, foul smelling. Progressively, the amount of food that is regurgitated increases, and slowly there can be aspiration, which is producing a life-threatening situation. And small amounts of aspirations can produce pneumonia, that is lung infection. The food material that is aspirated can produce a lung abscess, bronchiectasis. So this slowly progresses over the years, and then a carcinoma can develop. So now what is the diagnostic gold standard test is? You must demonstrate that there is increased pressure of the lower esophageal sphincter and absence of peristalsis in the esophagus. So manometry, esophageal manometry is the gold standard for diagnosis. There are two fancy tests you should remember. Cholecystokinin test. When you give cholecystokinin, normally the LES relaxes. But now, instead of LES relaxing, paradoxically it contracts more. This is called CCK test. Why this is? Because in achalasia, the nerve mechanism is not there. So it cannot relax with CCK. So when this inhibitory effect of CCK is absent owing to the loss of inhibitory neurons, and because of this, paradoxically it contracts more. There is no relaxing mechanism, right? There is another test called Mecholile test. When actually this Mecholile test is to differentiate achalasia cardia from other esophageal motility disorders. Diffuse esophageal spasm is another disorder. We want to know whether this patient is having an esophageal spasm, or it is because of the lower esophageal sphincter mechanism that is there. So in Mecholile, when you inject low dose of methylcholine, there is spasmodic contraction where patient will have severe pain. So now what do you treat? So now you have to relax, give nitroglycerils, calcium channel blockers, nitrates prior to meal. And then sometimes boogie dilatation in the early stages of the disease. 54 French, this is a question. 54 French may be offered. This is the early part. Next is injection of botulinum toxin at the lower esophageal sphincter. These are only temporary. Now, when the patient is suffering more, what you have to do is a Heller's myotomy. That is, you incise the lower esophageal sphincter. How much? 2 centimeters above the GE junction to 1 centimeter over the stomach. So about 3 centimeters, you have to incise the sphincter. Once you incise the sphincter, that is seromyotomy. This is called seromyotomy. Only the myotomy, the muscle layer is since there is not much of adventitia, only the muscular layers are there. You incise the longitudinal and the circular muscle fibers of the esophagus. Now the mucosa and submucosa pout out through this incised segment. But now this LES is divided, so you have to do some fundoplication for continent mechanism. So now let us do some bits on the achalasia cardia. So now here a female patient has dysphagia, intermittent epigastric pain. On endoscopy, esophagus was dilated above and narrow at the bottom. So what is it? See here, see they have directly asked the treatment. They have not mentioned you that what is the condition. So you have to understand the symptoms. You yourself have to put a diagnosis. Then you yourself have to give a treatment. So here, like this, you have to apply your knowledge sometimes. Aims bit. This is an aims bit. So here you see, you have a dysphagia. Any dysphagia means related to esophagus. Up to cardioesophageal junction, Any esophageal complaints are dysphagia, that is difficulty in swallowing. This is also having epigastric pain. They have given a picture of, sorry, endoscopy, dilated esophagus, narrow at the bottom. So what do you have to know? You understood what is the picture on endoscope where there is a cave-like esophagus. It is described as a cave-like esophagus. So this should be a case of achalasia cardia. So the treatment should be Heller's cardiomyotomy. You understood, students, why I have selected Heller's cardiomyotomy? Students? Hello, students?
Yes, ma'am.
Oh, please be fast. Have you understood? Now amyl nitrate inhalation
Yes,
test.
ma'am.
You know, amyl nitrate is a smooth muscle relaxant. So when do you want to relax? When there is spasm. So when there is the spasm is the basic pathology. So achalasia cardia should be the answer where there is spasm of the sphincter. So amyl nitrate. So in amyl nitrate inhalation, this fails because there are no nerves there. So it fails to dilate. In esophagus also, it does not arise. Esophageal diverticulum and then tragus. If we don't select this test for diagnosing these conditions, for esophagus you do an endoscopy and visualize the growth. And for a tracheoesophageal fistula, you do a barium meal swallow. Then for esophageal diverticulum, again barium swallow. So achalasia cardia is related to some smooth muscle problem, and amyl nitrate is to know the smooth muscle relaxation. So amyl nitrate and achalasia cardia go together. So this must be the answer. Now, increasing difficulty in swallowing both for solids and liquids in a woman with bird's beak appearance in X-ray. See how many they have given. So in achalasia cardia, the patient can neither swallow solids nor liquids because the lower esophageal sphincter is not relaxing. But in case of a carcinoma esophagus, first it starts with solids. Then because of the spread of the growth, there is obstruction to the esophagus, and next liquids. So from solids it goes to liquids. That is an esophagus. But for achalasia cardia, both solids and liquids one cannot ingest. Then they have given a bird's beak appearance. I'll show you what is this. Bird's beak. I described cave-like dilated esophagus with narrowed lower end. This is called bird's beak appearance. So achalasia cardia is the bird's beak appearance. I'll show you the picture now. A 30-year-old woman comes with dysphagia for both solids and liquids, and barium swallow shows parrot beak appearance. Esophageal manometry showed lower esophageal pressure is increased. What is the management? So directly they're asking treatment here. They have not uttered a single thing about achalasia cardia. So here first you have to see solid and liquid is dysphagia means achalasia cardia. Parrot beak appearance or bird beak appearance, achalasia cardia. Manometry, increased pressure in the lower esophageal sphincter, achalasia cardia. So now what are the treatments? See, this is a PGI bit. So multiple answers can be there. Nitrates. Can we give? Calcium channel blockers, botulinum toxins, myotomy. So all can be given. So A, B, C, D is the answer. Right? Now, Heller's operation, again I told you, achalasia cardia. For a hiatus hernia, you do a fundoplication. For a diaphragmatic hernia, you do a repair of the hiatus again. Next, reflux esophagitis, again you do a fundoplication. Right? Now, all are true about achalasia except predisposes to malignance. Is it true or not? Students?
Yes, ma'am.
Yes, ma'am.
Yes. Now, body peristalsis
Yes,
is
ma'am.
normal. Is it true? I told you the neural.
Yes, ma'am.
No. The body peristalsis is not normal because the nerves are not so, the neurons are not properly placed. So the peristalsis is, there is abnormality not only in the lower esophageal sphincter but also in the body. You just remember body and LES both are abnormal here, more in the LES. So this is wrong. LES pressure is increased. Is it right or wrong? Is it?
Yes, ma'am.
So this is true. So A is true, C is true. Dilatation of proximal segment. Is it true or wrong? False? Because lower esophageal sphincter is spasmodic, the proximal segment is dilating, right? Passive dilatation. So A, B, A, C, D are true. So the B is obviously wrong, right? Next, all are manometric features of achalasia except high LES pressure. Yes, decreases LES relaxation. Decreased LES relaxation. Yes, segmental body peristalsis. Manometry helps in diagnosis. So C and D you have to select. High L, right? So lower esophageal sphincter is not relaxing. High pressure is there. Then body peristalsis is not segmental. That is not, it is not a progressive peristaltic wave. There is abnormal, no? So this is abnormal. Manometry is the gold standard, I told you. Manometry helps in diagnosis, right? So now, see here, a female patient has dysphagia, intermittent epigastric pain. On endoscopy, esophagus was dilated above and narrow at the bottom. The treatment is again, see, AIMS bit. They're not giving you diagnosis. They're giving you physical, the clinical features they're giving investigations. They're asking you to choose the treatment. We all know, here see, all surgical treatments are given. So here, PPI, esophagectomy for a cancer, GERD proton pump inhibitors, antacids are given, dilatation or Hellers. So the dilatation is only a temporary. Hellers is the treatment. So Heller's myotomy should be the treatment. See here, you can see you are giving an incision on the cardioesophageal junction 2 centimeters and onto the stomach 1 centimeter. So here you can see the myotomy. The longitudinal and the circular muscles are cut. The mucosa and submucosa are pouting out now. Now you have to do a fundoplication, whatever method you want to choose. If it is Nissen, Stoppe, Dor, Watson, Belsi-Marfo. So this is the thing. Now, another question. Amyl nitrate inhalation test is used to detect straight away achalasia cardia. We have done this bit. So dysphagia for solids and liquids means achalasia cardia. So I think here again same things. Okay. In achalasia cardia, pressure at distal end increased. No peristalsis. Yes. So this is a PGI bit. That means multiple correct answers will be there. So low pressure at LES with no peristalsis. Do you agree? Is there high pressure or low pressure at lower esophageal sphincter?
High pressure.
Very good. So the LES is not relaxing. So this is wrong. Pressure is more than 50 millimeters mercury with peristalsis. There is no peristalsis now. So this is wrong. Pressure at the distal end increase with normal relaxation. No, it is not relaxing. So this is wrong. So what we are left with now is pressure is increased, no peristalsis. Do you agree with me for the answer, students?
Yes, ma'am.
Option A.
Very good, very good. So now, defect in achalasia cardia is the myenteric plexus of airbags. The neurons are absent. Radiological features suggestive of achalasia cardia. Absence of gastric air bubble, which is a feature of esophageal atresia. It may be also air, because the sphincter LES is very hypertonic. The gastric air bubble, the air may not go, esophageal air. So it can be air fluid level in the mediastinum. Yes, the esophagus is dilated and cave-like. The fluid, the food is there in it. So an air fluid can be there in the mediastinum, in the cardiac shadow. sigmoid esophagus, that is dilated esophagus. All of the above. So the answer should be all of the above. Do you agree with me, students?
Yes, ma'am.
So you should be careful. Just because all of the above is there, you need not show. But two are matching now. B and C also you can keep. A doubtful, but still absent gastric air bubble can be there. But this is the diagnostic feature in esophageal fistula. So you should be very esophageal atresia. So you have to be careful when just because all of the above is there, it may not be correct. You have to be careful and choose the answers. Next, all are true of Achalasia cardia except dysphagia. Yes or no? Yes. Aspiration pneumonitis. Yes. Mercurial test is hypersensitive. X-ray finding of dilated. See, Mercurial sensitive is sensitive. It is not hyposensitive. So this is wrong. Right? Do you understand? Have you understood?
Yes, ma'am.
Good. So Mercurial test is I've just put one. Cardiospastic is they want to differentiate between the esophageal spasm between cardia, Achalasia cardia. So patient who is given this methylcholine, there is severe spasm. In patients with symptomatic diffuse spasm typically complain of pain. Regurgitation is rare. So in cardiospastic esophagus, hypersensitive fashion to paras. So in Achalasia cardia, it will become hyperspasmodic, while in diffuse spasm, it is less spasmodic, right? Next, which drug is used? Again, nifedipine, calcium channel blocker is used. Next, again, same we have repeated. See here you can see the cave-like dilated, smooth esophagus with a trickling of barium. This is giving a smooth appearance. Smooth means it is benign. If it is irregular means it is a carcinoma. Even carcinoma also there can be a absence of there can be an obstruction, but here it is smooth and it is looking like a bird's beak. So this is called bird's beak or a pencil tip or rat's tail. There is no filling defect as such. This is called, if they say rat's tail deformity and filling defect means it is malignancy. Only rat's tail appearance means it is Achalasia cardia. So here, so these are the features. So in next class, I will complete esophageal motility disorder and other small little things like perforation, borowies, and carcinoma of the esophagus. Thank you, students. We have been for 1.5 hours now. I have discussed about the anatomy, physiology of the esophagus, and we have done some bits on that. We have done on diaphragmatic hernia, hiatus hernia, gastroesophageal reflux disease, and Achalasia cardia. Have you followed what all I have told you, students?
Yes, ma'am.
Very good.
Yes,
So
ma'am.
now, after the esophagus is completed, let us do whatever you want that what is being taught to you also, though you can choose the class that you want to be taken, whether it is your fourth semester, the semester class that you are doing, like you are in 6th semester, so your syllabus, or you want me to continue and go to other topics. Thank you so much, Chaitanya, Harsha, Sirisha. 3 names I have got. Thank you, students.
Thank you,
Bye.
ma'am. Thank you, ma'am.
Good night.
Bye.
Bye. Bye.
Good night.
Madam,